Welcome to The Explainer. All right, let's jump right in. Today, we are breaking down the practical, need-to-know guide for treating iron deficiency. This is built for you, the busy medical trainee, just the high-yield info you need to make smart calls on the fly. So first off, just how big of a deal is this? Well, over 12% of the entire world's population is dealing with iron deficiency. That is a staggering number. It makes it the single most common cause of anemia on the planet. So this isn't some rare diagnosis you'll see once in a blue moon. It's something you're going to see every single day. But here's the crucial point, and if you only remember one thing, make it this. Anemia is a late finding. It's the end of the story, not the beginning. See, your body is incredible at protecting its hemoglobin. It will literally scrape the bottom of the barrel, draining every last bit of its iron stores before that hemoglobin number even starts to budge. So a normal CBC can give you a totally false sense of security. And that's exactly why we have to talk about treatment, because the iron deficiency itself, even without any anemia, has major consequences for your patients. It's a whole body problem that goes way beyond just red blood cells. A lot of patients have these vague but really debilitating symptoms. And the wild part is, they often only realize how bad they felt in hindsight after you fix their iron levels. They'll come back to your clinic and say, wow, I didn't realize how exhausted I was until I wasn't anymore. And you see that ice craving, pagophagia? That one is super specific for iron deficiency. It's a classic clue. Okay, so you've nailed the diagnosis. Now you're at the main fork in the road. Do you go with oral iron or do you use intravenous iron? This is a huge decision. It's going to impact everything from how your patient feels to whether they even stick with the treatment. And here's the fundamental trade-off. You've got oral iron on one side. It's cheap, it's easy, it's the usual default. But, and this is a really big but, up to 70% of patients get hit with nasty GI side effects. We're talking constipation, nausea, it makes them feel awful, and they just stop taking the pills. Then you've got IV iron. It's a total game changer. It's fast, it's super effective, and it completely bypasses the gut. Now, if you do decide to go the oral route, it is absolutely critical to know that the old way of doing things, telling patients to take multiple pills a day, is being replaced. There's a much smarter, evidence-based strategy now that works better and is way easier for patients to tolerate. So what's the science here? Well, it all comes down to this hormone called hepcidin. Think of hepcidin as the gatekeeper for iron absorption in your gut. When you flood the system with a big dose of iron, hepcidin levels skyrocket and basically slam the door shut for about 24 hours. So get this, giving more iron can actually make your body absorb less. You're just causing more side effects for no reason. So the modern approach is all about less is more. You give a simple iron pill just once every other day. This lets those hepcidin levels come back down, which means you maximize the absorption from each dose. The best part? The GI side effects are drastically reduced, so your patients will actually stick with it. It's a win-win. But please don't forget, you have to keep the treatment going for 3 to 6 months after the hemoglobin is normal to actually refill their stores. Okay, but what about those times when you should just skip the oral route entirely and go straight to IV? There are definitely clear situations where trying oral iron first isn't just a hassle, it's pretty much guaranteed to fail. And this is a question you'll face all the time in the hospital and in the clinic. Learning to spot these patients right away can save them months of feeling lousy on a treatment that was never going to work for them in the first place. And here are your prime candidates. Think about it. A patient with inflammatory bowel disease, oral iron gets poorly absorbed and it can even make their IBD flare up. Someone who's had gastric bypass surgery, they literally don't have the anatomy to absorb it properly anymore. A patient in her 3rd trimester of pregnancy, you don't have the luxury of time. In these cases, IV iron isn't just another option, it's really the standard of care. Lastly, how do you know if your treatment is even working? It's not enough to just write the script and walk away. You've got to define your targets and then follow up to make sure you're actually hitting them. You should see a pretty predictable response. The very first sign of success, usually within a week, is a jump in the reticulocyte count. Those are the new baby red blood cells. Then the hemoglobin will start to climb over the first month. But remember, a normal hemoglobin level is not the finish line. Your ultimate goal is to completely replenish the body's iron stores, and that means you keep treating until the serum ferritin is at least 50. In some situations, like for patients with restless leg syndrome, you might even aim higher. This is what gives them a reserve, a buffer, to keep them from becoming deficient all over again. And this brings us to the most important point of all. Replacing the iron is just treating the symptom. Iron deficiency in an adult is almost always a sign that something else is going on, usually some kind of blood loss. Your job isn't truly done until you've answered the question, why did this happen in the first place? Finding that answer, that's the real challenge. And that's the key to preventing it from ever happening again.